Committee and KDIGO for the invitation to speak at this meeting. Today I'll be highlighting some of the key messages from the recently published KDIGO Guideline on the management of diabetes in people living with chronic kidney disease. These are my disclosures. Following a controversy conference held in 2015, KDIGO commissioned a working group with diverse backgrounds to develop a set of guidelines on diabetic kidney disease. Now, this working group consisted of nephrologists, cardiologists, endocrinologists, family physicians, clinical trial specialists, and we had dietitians, and most importantly, patients. The working group had met twice on a face-to-face basis and went through a series of iterations to develop the guidelines in its current published form. Now, before I go into the guideline proper, perhaps I would like to highlight the format of the guideline. Now, KDIGO has recently adopted a brand new format in presenting its guidelines, where clinical recommendation statements are interspersed with practice points. Now, this slide highlights the summary document that is provided in the guideline, and it explains the differences between clinical recommendations and practice points. Clinical recommendations are graded on the strength of the recommendation as well as the quality of the evidence. Now, level 1 is a strong recommendation and is articulated by we recommend, and level 2 is a weaker recommendation and stated by we suggest. Now, the quality of the evidence is divided into 4 different grades, A to D, where grade A is given when there is a high quality of evidence, and grade D when there is a very low quality of evidence. Practice points, on the other hand, are not graded for strength of recommendation or quality of evidence. They are largely the expert opinions of the working group and are consensus statements regarding an aspect of care where the evidence is lacking or is of extremely poor quality. Now, occasionally, they make reference to observations for which studies have not yet been performed but are of clinical significance, whereby the working group felt that the lack of clinical guidance will have a detrimental effect on outcomes. So practice points may take the form of a clinical statement, a figure, a table, or even an algorithm. The final guideline is divided into 5 different chapters that's listed in this slide. Now, in the interest of time, I would not be able to go through every single chapter or clinical recommendation statements. I would instead highlight some key messages in the guideline that may require more discussion or have important clinical implications. Let's begin with Chapter 1, which deals with comprehensive care. Now, Chapter 1 provides a general overview in the care of people living with diabetes and chronic kidney disease. Now, Practice Point 1.1.1 summarizes the approach in this chapter and state that patients with diabetes and chronic kidney disease should be treated with a comprehensive strategy to reduce the risk of kidney disease progression and cardiovascular disease. Now, the figure on the right here lists the various components of this comprehensive strategy. And one of the key components of comprehensive care is articulated in Clinical Recommendations 1.2.1, which deals with the importance of using renin-angiotensin system blockade in our patients. Now, the statement reads that we recommend treatment with an ACE inhibitor or ARB be initiated in patients with diabetes, hypertension, and albuminuria, and that these medications should be titrated to the highest approved dose that is well tolerated. And this is given a grading of 1B. Now, the data for the use of RAS blockade in individuals with diabetes and associated hypertension is well established with well-designed trials such as RENAL, IDNT, IRMA2, and innovation studies demonstrating their benefits in renal protection and reduction in the risk for mortality. Now, however, the use of RAS blockade agents in the diabetic population without hypertension is more contentious. So while most of the studies evaluating RAS blockade in people with diabetes included individuals with hypertension exclusively, the RENAL study and the innovation trial recruited a proportion of people without elevated blood pressure. This was about 3.5% in the RENAL study and about 31% in innovation. Now, the innovation trial also conducted a subgroup analysis of the non-hypertensive cohort and found that individuals without elevated blood pressure who were randomized to receive telmisartan had a reduced risk of transiting to worsening stages of diabetic kidney disease in a dose-dependent manner. So therefore, while the data is limited, now in the absence of a preferred therapeutic agent, the work group proposed in practice point 1.2.1 that ACE or ARB treatment should be considered in patients with diabetes and albuminuria but have normal blood pressure. Now, because of the key importance of ACE inhibitors and ARB in mitigating the progression of diabetic kidney disease, the guideline also provided guidance on managing scenarios where RAS blockade may be easily stopped, so that all attempts can be done in ensuring as many patients stay on the treatment as possible. Now, these include hyperkalemia, as well as an acute rise in serum creatinine after starting or increasing the dose of ACE inhibitor or ARB. Now, other measures such as these listed here should be implemented first when these clinical situations occur before stopping the drug prematurely. We will move on to Chapter 2, which deals with glycemic targets. Now, in clinical recommendation 2.1.1, we recommend that HbA1c be used to monitor glycemic control in patients with diabetes and CKD, and this is with a 1C grading. Now, while there are situations in patients with CKD where the value of HbA1c may not be accurate in assessing glycemic control, HbA1c is still a good prognostic marker for the development of micro and macrovascular complications. The guidelines do provide information in which HbA1c may underestimate or overestimate glucose control, so that the clinician may be aware as kidney failure progresses. Now, practice point 2.1.2 draws attention to these situations and highlights some of the nuances of using HbA1c in estimating glycemic control in patients, especially in advanced CKD. Now, following this, clinical recommendation 2.2.1 recommends an individualized HbA1c target ranging from 6.5% to 8% in patients with diabetes and non-dialysis dependent CKD, and this is given a 1C grading. Now, the spirit behind this recommendation is really to balance the benefits of tight glycemic control with organ protection and the risk of life-threatening and symptomatic hypoglycemia, especially in specific high-risk patient groups. So in people who are elderly with many comorbidities or shortened life expectancy, or where kidney failure is advanced, a more liberal HbA1c target is acceptable. And finally, I would like to spend more time discussing some of the recommendations coming out of Chapter 4, which deals with anti-glycemic therapies. Now, this has been an exciting time where data has been coming out with novel therapeutic agents, and definitely this chapter commands a much greater attention and time in discussing the clinical recommendations. This chapter opens with recommendations and practice points on the use of metformin as a predominant treatment for hyperglycemia. Now, in fact, recommendation 4.1.1 stated upfront that in patients with eGFR greater than or equal to 30, we recommend that metformin be used as the first-line treatment for hyperglycemia. Now, the rationale for this comes from several clinical benefits with the use of metformin, including weight loss, the lower risk for hypoglycemia, and some possible suggestion of cardiovascular protective effect. In addition, metformin is widely available in many parts of the world. It is one of the cheapest medication and has been around for a long time, so physicians are also more familiar with its use. Now, I want to highlight that metformin is being recommended as a first-line treatment for the purpose of hyperglycemia and not so much for organ protective effect. And following these recommendations, there are a series of practice points on the use of metformin in patients who has a kidney transplant. And it also provided guidance on the need to monitor eGFR and the need to adjust the dose of metformin as kidney failure progresses with a reduction in the eGFR. In practice point 4.1.4, we also suggested monitoring patients for vitamin B12 deficiency, which has been reported in prolonged usage of metformin for more than 4 years. So together with these practice points, focusing on the practicalities of using metformin, this figure summarizes some of the expert opinion on the dose reduction required for metformin with worsening kidney function. It's also provided some suggestion on the monitoring frequency of the kidney function as well as that for vitamin B12 deficiency with prolonged use. The guideline will also provide an approach in managing the concerns of lactic acidosis with the use of metformin, and this is generally assessed to be of low risk, even in the population to reduce eGFR if the clinical situation is being managed appropriately. I will not spend too much time on this as these are nicely summarized in the guidelines. Then, as we move on further into the chapter on anti-glycemic therapies, one would notice the clinical recommendations that came about from the various organ protective trials of novel anti-glycemic agents over the later half of this decade. Now, it was only in 2015 when the first trial on SGLT2 inhibitors opened up the exciting field of this class of drug in not just cardiovascular protection, but also the possibility of reducing renal endpoints in a way that is much bigger than BRAS blockade. And not too long after that, in 2016, results of the LEADER trial highlighted the possible benefits of another novel anti-glycemic agents, GLP-1 receptor agonist, in a similar manner. So naturally, many clinical practice recommendation guidelines have undergone several changes in response to these new cardiovascular outcome trials, as well as subgroup analysis of renal endpoints. And this is summarized in this slide. You will notice that most, since the publication of the EMPA-REG study, as well as even the LEADER trial over the period of 2016 to 2018, there have been new changes made to various international guidelines. Now, hence, based on the outcomes of the systematic review performed by the evidence review team, the working group put forth clinical recommendations 4.2.1, which states that in patients with type 2 diabetes, chronic kidney disease, and eGFR greater or equal to 30 mL per minute per 1.73 meters squared, we recommend including an SGLT2 inhibitor in the anti-hyperglycemic treatment regimen. And this is the only 1A recommendation in the entire guideline. And because this is a novel therapy, the guideline also provided several practice points that are listed here. So it gives guidance on the addition of SGLT2 inhibitors to individuals who has good glycemic control or who has poor glycemic control, and the choice of SGLT2 inhibitor in practice point 4.2.3 should prioritize agents with documented cardiovascular or kidney benefits and take the eGFR into account. Now, this recommendation came hot on the trails of the overwhelming results of the CREDENCE study. Now, this was the first published trial evaluating the use of SGLT2 inhibitors in individuals with type 2 diabetes and diabetic kidney disease, and having renal endpoints as a primary outcome. So the primary outcome is a composite kidney endpoint inclusive of doubling of serum creatinine, the occurrence of end-stage kidney disease, or death due to cardiovascular or kidney disease. Now, the study recruited about 4,400 patients with a mean eGFR of 57 and albuminuria close to 1 gram a day, and found a 30% reduction in the risk of the primary outcome, and similar effects were also seen with the reduction in the risk of end-stage kidney disease alone. A systematic review of the CREDENCE as well as the other 3 major cardiovascular outcome trials of SGLT2 inhibitors, namely DECLARE, CANVAS, and EMPOWER-REG outcome studies, further strengthened the significant benefits of SGLT2 in both cardiovascular and renal protection. Now, these benefits were consistent. The magnitude of the effects was significant and with high precision, therefore earning this clinical recommendation high grading of 1A. Now, and the recent publication of the DAPA CKD trial will further strengthen this recommendation, because 2/3 of the study population in the DAPA CKD study included patients with type 2 diabetes and diabetic kidney disease, and the study had also shown similar benefits of dapagliflozin. Therefore, in the approach of using SGLT2 inhibitors in people with diabetic kidney disease, consideration is made to use SGLT2 inhibitors for the purpose of organ protection, meaning for the reduction in the risk of progression of diabetic kidney disease, or to harness the cardioprotective effects of the drugs. And SGLT2 is not really used for the main purpose of glycemic control. In fact, most of the published studies suggested that SGLT2 inhibitors has a modest effect on HbA1c reduction, and really just reduces HbA1c by about 0.5 to about 0.9 or at most 1%. Therefore, in a patient with well-controlled blood sugar profile, a reduction in the other diabetic medication should be considered to make way for the use of SGLT2 safely. And because SGLT2 inhibitor is a novel therapeutic agent, many may not be familiar with the side effect profile of the drug. Now, in particular, we would like to highlight the risk of euglycemic diabetic ketoacidosis, which have been found to increase by 3-fold with particular clinical situations in people taking SGLT2 inhibitors. Therefore, in practice point 4.2.4, we wanted physicians to be aware that during periods of prolonged fasting or critical medical illness where the risk of ketosis is high, SGLT2 inhibitors should be withheld, or if necessary, patients should be screened for the development of ketoacidosis, as the blood sugar profile may be normal and not be elevated in the traditional diabetic ketoacidosis presentation. The rest of the practice points that follows the recommendations on SGLT2 inhibitors also provided guidance and information with regards to some of the other common side effects of SGLT2, such as hypovolemia, and it also provided some guidance on what to do with SGLT2 when there is a decline in the EGFR, or when the EGFR falls below the recommendation of 30 mL per minute per 1.73 meters squared. In practice point 4.2.8, we have also stated that SGLT2 has not been adequately studied in kidney transplant recipients, but because they are immunosuppressed and potentially at increased risk for infection, the recommendation to use SGLT2 inhibitors does not apply to kidney transplant recipients. So moving away from SGLT2 inhibitors, we recommend in recommendation 4.3.1 that GLP-1 receptor agonists be used in individuals who are not able to achieve the glycemic targets despite the use of metformin and SGLT2 inhibitors, or when these two agents are contraindicated, for example, in cases of advanced kidney failure. Now, this is given a 1B recommendation. Now, this recommendation is supported by the evidence of the cardioprotective effect of GLP-1 receptor agonists. A systematic review of the 7 major cardiovascular outcome trials with GLP-1 receptor agonists found that the use of these agents is associated with a 12% reduction in the risk for 3-point MACE or in cardiovascular deaths. Now, in addition, there was some suggestion that GLP-1 receptor agonists have some kidney protective benefits. Now, in the same meta-analysis of the 7 major cardiovascular trials, the use of GLP-1 receptor agonists showed a 17% reduction in a composite kidney endpoint, which included new onset albuminuria, decline in EGFR, development of ESKD or renal death. Now, I would like to highlight, however, that this effect was driven mainly by the development of new onset macroalbuminuria and less so by heart renal outcomes. So therefore, the data for GLP-1 receptor agonists is not as strong yet as when we compare it with SGLT2 inhibitors for kidney protection. But GLP-1 receptor agonist is an attractive option as there is no requirement for dose adjustment in patients with progressive decline in kidney function. Dulaglutide, for example, may even be used in patients with advanced stages of CKD with EGFR greater than 15. So indeed, these are exciting times for the field of diabetic kidney disease, where for a long period of time, only RAS blockade had shown significant protective effect against kidney failure. There are ongoing trials on not just SGLT2 inhibitors and GLP-1 receptor agonists, but also on the effect of new mineralocorticoid antagonists in diabetic kidney disease. Now, taking on from the DAPA CKD trial, the EMPA kidney study will examine further the effect of empagliflozin on kidney disease progression or cardiovascular deaths in individuals with chronic kidney disease with or without diabetes. The FLOW renal outcome study will specifically evaluate the effect of semaglutide, a long-acting GLP-1 receptor agonist, using kidney endpoints as the primary outcome. And the Fidelio DKD study will examine the benefits of a new mineralocorticoid antagonist, finerenone, on reducing cardiorenal morbidity and mortality in individuals with type 2 diabetes and chronic kidney disease. Now, these upcoming new trials will definitely provide more data on how we would use the armamentarium of drugs that we currently have in reducing the progression of diabetic kidney disease. Therefore, to summarize the overall approach to anti-hyperglycemic therapy in individuals with diabetic kidney disease, lifestyle modification continues to be general management goals. Metformin and SGLT2 inhibitors will form the backbone for the baseline pharmacological therapy, where metformin is used mainly for the purpose of glycemic control, and SGLT2 inhibitors for organ protection, predominantly cardioprotection and kidney protection. Additional drug therapy are considered based on a few factors and should be individualized to the patient, taking into account patient preferences, comorbidities, the eGFR, as well as the cost. And the guideline summarizes nicely the personalized approach to anti-hyperglycemic agents, matching the different clinical scenarios to the preferences and suitability for particular therapy. So, for example, this very nice summary figure suggested for patients with low eGFR, the more suitable medications would include a DPP-4 inhibitor, insulin or sulfonylurea, thiazolidine, as well as alpha-glucosidase inhibitor. If one is managing someone with a significant risk of hypoglycemia, sulfonylurea and insulin should be avoided, and because they are of higher risk for developing low blood glucose, and other drugs should be considered. So these should be a mix and match and provide a personalized approach in managing our patients. So to summarize, now this is the first published KDIGO guideline on diabetes and chronic kidney disease. It provides recommendations and practice points on 5 different areas, which included comprehensive care, glycemic monitoring and targets, lifestyle interventions, the use of anti-hyperglycemic therapies, as well as approaches to the management of patients. Now, patient-centered decision-making and support and consistent efforts at improving diet and exercise remain the foundation of all glycemic management. Control of risk factors, including the use of RAS blockade, remains part of the standard of care. We have suggested that glycemia continue to be monitored with HbA1c and to be supplemented with blood glucose when necessary. Glycemic targets should be individualized with focus on the increased risk for hypoglycemia with declining renal function. We suggested and recommend the use of metformin as the initial therapy for the purpose of glycemic control, and this should be followed by SGLT2 inhibitor when organ protection is necessary. GLP-1 receptor agonists could be used, therefore, as an alternative. And with that, I thank you for your kind attention.